Awesome.
Okay, great. So welcome everyone. Can everyone just let me know if you can hear and see both of us okay? And I think I should be sharing the screen as well. Yeah, great. Okay. So, welcome everyone to this Cambridge University Aerospace Medicine Society talk. I'm really honored to have Dr. Jonathan Clark here. So, Dr. Clark has a very impressive CV. So he's worked with NASA on 6 space shuttle missions, working as the space shuttle crew surgeon. And he's also served extensively in the US military in different branches. So he's been with the US Navy. He's also been part of the US Army parachutists, and he's been a Navy diver as well. And he's been flown out to combat medical evacuation missions as a part of Operation Desert Storm as well with the US Marines. Outside of the kind of US military and space remit, he's been working on some private projects as well. So he's a consultant with Virgin Galactic and also SpaceX, and he's worked on various projects such as the Red Bull Stratos project, which is the stratospheric balloon free fall parachute flight. So as you'll see, Dr. Clark has extensive experience in kind of the neurological side of aerospace medicine. And he also specializes in crew resilience as well. So without further ado, please let's welcome Dr. Clark.
Hey, thanks for having me. It's a great honor to be able to talk to you all. My role at my stage of career is to basically pass the torch to the next generation. So this is basically going to be hopefully an enlightenment on some of the neurologic effects of spaceflight. So we'll just get right into it. The next slide is, you want to pull that up? It's
Yep.
Basically, some of our objectives for the lecture would be to understand how the nervous system is affected by space. And we'll talk about, there's a multitude of environments that we're dealing with. We'll talk about some specific neurologic syndromes, particularly as they relate to certain phases of space flight. And then the key thing is, because of the requirement for astronauts to do things, and this applies even to commercial spaceflight participants, they might not have crew duties, but they certainly have duties in case of contingency. Invariably, the effect on the nervous system influences performance. I'll go through some examples of that. Next slide. Unfortunately, the videos that I had weren't able to come through, so I'm basically going to just do a text and picture only presentation. We're going to talk about a lot of different things. We'll just skip through this. I have a copy of this available if you're interested. Go ahead to the next slide. What we'll do is I always like to start with giving folks an idea of how much time people have spent in space. There's somewhat controversy about where space is. Yeah, the U.S. In the early 60s said that space was 50 miles. And the Federation Aeronautic International said, we always like round numbers, and they said it was 100 kilometers, which is 62 miles. So there's often a debate, especially in the suborbital flight, because Virgin Galactic can get international standards, but they do the U.S. standards. Anyway, just looking at it, there's only been 616 people who've flown in orbit, which is a little bit harder to get than just a suborbital flight. And we have now as of this month, about over 100.
Uh, Dr. Clark, I think I think you just dropped
Sorry,
out for a bit there.
yeah, we've had bad weather here, and there may be, for some reason, the internet's not doing real well. We can go to the next slide.
Okay, sorry about that.
It'll drop out. So this is a neat little chart that talks about specific brain spaceflight stressors by a colleague I work with, Ajit Movari. And obviously gravity is a huge factor, but there's also other things that are, as we'll get into it, that are certain effects on the nervous system, and as well as, the behavioral performance side of things. We often separate neurology from psychiatry and psychology, but the fact is that they're both interrelated. Next slide. So, been exposed to since we were born, in the womb, we're somewhat suspended in a fluid. There's still gravity, and gravity is a very important aspect of our physiology and homeostasis. We have people that have been in space, and there's actually one person that's spent over 900 days in space, and quite a few that have been over 500 days. And they have, I would point out, and I have a cool video of it, but when you put an embryo in development in the absence of gravity, they get very morphologic skeletal changes. And if you add artificial gravity at a certain stage, they can recover, but you get very dysmorphic creatures that will not survive just because of that. So gravity is something that's probably essential for us in some amount, fetal development. But right now, for adults and that are, have mature systems, the absence of gravity won't kill them. Slide. So this is a slide that talks about how as soon as you go to space, all your systems have an adaptive time constant as to what they're going to rapidly change and then reach that point. You'll see fluid changes that may take a couple of days, cardiovascular changes, changes in red cell mass, and then there's the longer time systems, such as in skeletal metabolism. Now, the thing is, those time constants don't reach a stable equilibrium in some of those long ones, such as bone. And right now, we see about 1 to 2% bone loss, bone mineral density loss. And we have missions up to about a year or a little over a year. But that loss seems to have continued. With countermeasures, that can be significantly reduced. And the one that you see up there, the dotted line, is radiation, and that's the one that is the real seriously unknown system effect. What radiation has effects on all of the different organ systems, particularly those that are rapidly dividing. And then on the next slide, what you'll see is what's the time constant for readaptation from the novel environment of space back to the terrestrial environment on Earth. And invariably, those time constants are not exactly the same as they were. So the adaptive time constant is often much shorter than the readaptive return back to terrestrial standards. For example, you may lose certain amounts of bone density in a 6-month mission, and it may take you 3 times that long to recover that bone density back to its normal state. So the bottom line is the adaptive time constant and the readaptive time constant are different. Next slide. So there are different ways you can break down of what are the various factors that relate to this, how the body is affected. And I like to break them down into ones that we'll talk about in a little bit. But just on what I'm showing you here is there's multiple things that affect the nervous system. And it's not just the altered gravido-inertial environments. It's also the visual motion environments, particularly when you're looking at a display doing a robotic operation. And then we also use countermeasures.
Dr. Clark?
Next slide.
Hello, Dr. Clark?
Slide.
Sorry, I think we lost you there for a few seconds.
Yeah, shit,
Sorry
this
about
is
that.
going to be a real challenge. So let's break it down by the various phases of flight. We typically have essentially the pre-flight stage. The ascent is the high chemical energy transition state. You know, we're turning chemical energy into kinetic energy, getting to space. That is a very dynamic environment with motion. And that's one we'll see quite a bit of effects, particularly because it's a very dynamic motion environment with vibration and G loads. So you see a lot of difficulty, say, reading an instrument panel because of the amount of motion and vibration. And if you're having to do something like throw a switch or something else, you can have some challenges with that. The on-orbit phase, which is where you're doing to go to get work done in space, has several different things that we'll talk about: motion sickness, headache, and orientation issues. And we'll go through that in a little more detail. The next dynamic phase after the space mission is completed is to come back through a G-force on reentry, and that causes some components that it had on ascent, ocular instability, et cetera, et cetera. And then after you land, there's a certain period of time stable and related to the length of time you spent in space. So we'll talk a little bit more in detail about some of these. Next slide. Motion sickness is actually a very interesting thing because although it wasn't in the early US space program, it was in the very early Russian program. It got to be a substantial issue in the Apollo program because the crew were actually able to unstrap and get around and do things inside the command module and also in the lunar module. And this is a picture of you know, this was kind of a fake picture of what vomit would be like in the inside of a spacesuit, which would be really, really, really bad. In microgravity, you don't have things so the vomit could come back and you could aspirate it, which would be a serious problem. So we'll talk about space motion sickness. There's also, next slide, besides space motion sickness, there's also space adaptation syndrome, which is basically the puffy face, and I'll show you some pictures of that later on. So motion sickness in space is not the same as terrestrial motion sickness, either air sickness or seasickness, car sickness, anything like that. In fact, having one of the about some differences. You can obviously have the similar and vomiting and stomach awareness. But one of the things that's very interesting is that you can have a motion sickness syndrome without motion sickness, and that's called Sopite syndrome. And it's very, very interesting where you basically just feel like, you know, you have no energy, your motivation, and almost like you were drugged. And perhaps it's a form of the body saying, hey, something is very much out of the ordinary. And so your system basically just kind of turns itself off so you don't get hurt or injured. But the bottom line is you can have motion sickness, Sopite syndrome, without the standard symptoms of motion sickness. Crew are very sensitive to head movements. As we had larger and larger volumes inside of spacecraft, internal volumes to move around and do things, motion sickness has gone up as a result of that. So you can see that, you know, from Apollo, Skylab, and Shuttle, it's gone up to well over half the crew have symptoms. And they can, the symptoms, as soon as you have main engine cutoff, they can start to occur. And they usually last a couple of days, sometimes maybe 3 or 4 days before they resolve. Next slide. And this is just this was a shuttle crew taking the very, very over-engineered vomit bag. I think those things are over $100. I'm getting a warning that my internet is unstable. Next slide. So we can go through the next slide. That was pretty much mentioned on the previous one. The one thing that's really been a drastic difference in our mission scenarios, instead of flying these 2-week missions on the space shuttle, we're now flying missions in excess of 6 months routinely, and occasionally over or close to a year in length. And when crews have spent a significant amount of time, which would be probably over a couple of months in space, they are much more vulnerable to motion sickness when they come back. So the absence of gravity has a profound effect on the nervous system. In animals, you can see changes in the little otolith stones in your inner ear. You can see synaptic changes in the cerebellum and other structures. So it has profound effects on the actual wiring and sensors that our body used to give us cues into where we are in space. So we see motion sickness, and what you see there is the scale of this would be severe. You know, in other words, it's not like debilitating vomiting, but it's profound malaise in virtually all the crew members when they come back. And what does that mean is if you land without support from recovery forces, in other words, you land somewhere out of the ordinary, which has happened on not infrequent occasions, then you are totally out on your own. In other words, you're trying to do something, take care of yourself, make sure you survive, get into your life raft or set up, you know, survival shelters or whatever, and you're very, very affected. And it takes at least 12 hours for it to go to about half that amount. And that is something that everybody has to take into consideration. Is if you want issues. Next slide. And that's a picture of the two Progress, or those are Soyuz capsule attached to the bottom of the space station. And you can see the Aurora Borealis in the background. Next slide. So another thing that can happen and it may not be associated with motion sickness, is what they now call space headache, and that's now considered and classified as a new form of headache. And this was a study that was done about a decade or so ago. And what they found is that there was moderate to severe headache in about 3/4 of the astronauts that were tested or in this study. And it didn't have a specific type. It wasn't migraine with pulsatile. It could be tightening, tension headache, or non-specific. So anyway, the bottom line is that we now know that space headache is its own phenomenon. We'll talk a little bit about what might be the cause of that. Next slide. One of the things of oxygen, about 0.03 or percent of in the atmosphere, and in space it may be 50 to 100 times higher. And so occasionally it'll border on 0.5% or even close to 1%. And so what you see here is a relationship of headache probability with concentration. And it's not surprising, if you might remember some of your neurophysiology, the gas that has the most effect on central nervous system vascular flow is actually carbon dioxide. So if you have a high carbon dioxide level, it actually increases the volume of your blood vessels, and as a result of that, stretches pain-sensitive fibers. So it's not at all unreasonable to think, well, that's why you have headaches, is the carbon dioxide level. And part of it is that they don't like to change the scrubber systems out, and so they've been taking a set point of about 4 to 5 millimeters of mercury of carbon dioxide. And as I'm going to cut out my video here just because I'm trying to cut out bandwidth. They've started to reduce the carbon dioxide. Instead of 4 or 5 millimeters of mercury, they're going down to 2 and 3, and that's helping a little bit. You can see the plot says the CO2 levels have been reduced over on the far right, the green side, that it's dropped the headache levels as well. Next slide. The absence of gravity and the effect on the nervous system and the sensory organs is profound. And these are just some of the environments that you have to do. For example, crew that are out on a robotic arm, crew that are doing a capture of a satellite or doing something with a robotic system. They're basically seeing a screen and having to move their robotic arm, and then on the right side, what you see is a rendezvous and docking. And sometimes when you're doing that rendezvous and docking, you're seeing it from as if you were on the other spacecraft. Next slide. Laurel, I'm busy, honey. What? Okay, thanks. All right. So one of the perceptual illusions is that when you have the absence of gravity, when you first experience it, you actually feel like a bat hanging down upside down. And it's called the inversion illusion. And it actually, it was even experienced X-15 program that they basically were able to get to suborbital space, and the pilots would note that they basically felt like they were flipping backwards. Next slide. These will be available for you. And again, like I said, there's quite a bit of perceptual illusions. Basically, as humans, there's 3 ways you can decide what is down. What is down is where the vehicle floor is. What is down could be where the earth is, or what is down is where your feet are. And those things, the earth, the vehicle floor, and your feet are not always aligned appropriately. So basically astronauts will have, okay, what my normal scenario is that where my feet are is where down is. And if somebody comes into a structure where they see something different, like people upside down, there were times, like for example, in the shuttle program, where a crew member has been working inside the shuttle, and then he comes up on the flight deck and he looks outside and he sees the Earth in an unusual attitude, and that perceptual flop caused him to vomit. Next slide. So anyway, we'll skip through some of these. Let's just skip through those. That's what I was just talking about. You can decide where down is, and you can imagine. I'll go to the next slide with the. This is the crew are in the space station, and what you see is everybody's in a different attitude. It was a real problem in the Mir space station because each of the modules had a different vertical up and down. And three-dimensionally, as you can see there were some, because the crew would train in a module on the Earth, but the way they were hooked up together in space was different. And so crew would go from one module to the other, and automatically it would change its orientation 180 degrees. As a result of that, crew had difficulty finding their emergency escape path. Next slide. And you can see that in what they had to do on the space station is basically put placards out, just like on airlines, where it says, which way to the closest exit. Next slide. I'll talk about a sensory motor control issue. This was a study where they were having crew members point to an object that they saw that was in front of them. And what you'll see on the next slide is the chart of errors, and the difference between when you were on Earth in the top one and on the in-flight on the bottom one. And when you opened your eyes, you could reorientate for quickly and have a fairly correct response. But if you were doing this with your eyes closed and tried to point to where, say, straight ahead was, or point on the up, down, left, and right, you saw that everything was displaced downward. And what that is due to is that the perception of where the horizon is in the absence of gravity, you're always going to shoot low. Next slide, you'll see the difference too. And if you have a high G field, it actually causes your perception of where straight ahead or the center of the target is elevated. So that just shows you that from a pointing standpoint, that what you perceive is very dependent on the gravity field. The next slide shows you how that becomes a concern in operations, is that you often have to grab a switch with the little grasp extender. And if you have a visually degraded environment, say there's smoke or something in the cockpit or whatever, you're going to end up shooting low on that. So it's just one of those things you have to take into consideration. Next slide. It also may be responsible for some of the problems in crew with robotic ops. It's too bad we can't play the video, but this is called EVA height vertigo, or EVA acrophobia. And next slide, it was a great story that was by Jerry Leninger, who was the first U.S. astronaut to use the Orlan spacesuit. And he was talking about how he felt like he was falling the whole time he was doing the spacewalk. I'll just briefly mention some radiation concerns. Astronauts in space, when they're ready for sleep and their eyes are closed, if they're in a certain part of the orbit, they'll get retinal flashes. And those flashes are high energy particles that are basically stimulating the retinal ganglion cell to fire. Now you might think, oh, that must be kind of cool, but every astronaut I talk to, knowing now what they do, is they know that that's just a hit to their brain. So here you see where all the retinal flashes are, which are on the high latitudes, north and south, where the poles of the Van Allen belts dip down into. So it's not surprising that they're more present in the upper and lower extreme latitudes. And also there's a hole around it's called the South Atlantic anomaly, where those trapped ions can come into, and that's also where we see the retinal flashes. And on the next slide, what you see is where do we see computer bit flip changes, also called single event upset. So the bottom line is that these high energy radiation particles are bad for your body or your nervous system, and they're bad for integrated circuits, particularly high density ones. Next slide. So the one thing that is recently emerged in the last decade and a half has been a concern of what's called spaceflight-associated neurolocular syndrome. It was originally called visual impairment intracranial pressure syndrome, and right now we've had it in about 2/3 of crew. They will have some sign of this phenomenon, which is basically we're studying it and trying to get a feel for it, but it's something that is very different and very unique about space flight. The few times that we've had crew that we have never done a lumbar puncture in space to see what their actual intracranial pressure is, but we have done them in post-flight sittings, and several of those crew who have shown optic disc edema or papilledema, that they also have mildly elevated lumbar puncture opening pressures. Next slide. And the cardinal symptoms are optic disc edema or papilledema. The other thing that's interesting is if you take an ultrasound and you look at the eye in space, what you'll see is that the optic nerve sheath, which is basically a tube of spinal fluid that's around the optic nerve, is bulbous and expanded, and because of that, you'll see the optic nerve sheath expansion basically pushes on the back of the eye, and it creates globe flattening, and globe flattening essentially causes hyperopia. And that means that if you were have normal vision, it means that now you have a hyperopic shift, so you have a lot of trouble seeing something up close. The other thing is you can also see choroidal folds, which are basically buckling of the choroid in the back from that pressure shift. Next slide. And these are just some pictures. This was one of the first times done in Expedition 10 by Leroy Chow. And what you'll see there on the next slide is the ultrasound can show basically very tortuous optic nerve sheath. Can you go to the next slide? I was just sorry about this. What this causes operationally is there are crew that have said, I can't read my checklist. So that's the operational consequence of that. Next slide shows the tortuosity of the optic nerve sheath, and you can see that it's made the globe less circular or spherical, and you can see how the optic nerve has been kinked as a result of that. Next slide. We don't know exactly what's going on here. We've never measured intracranial pressure in space, but the indication of the optic nerve sheath diameter enlargement suggests that it's increased pressure. But it could be a number of things: fluid shifts, the gradient between where the optic nerve goes through this constrictive area called the lamina cribrosa may be a factor. You see increased intracranial pressure in clinical settings on Earth in what's called pseudotumor cerebri or benign intracranial hypertension. You can also see it from vitamin A toxicity, people that eat shark livers. So anyway, the bottom line is, even though we've been studying it for well over a decade, we're still not exactly sure what's exactly the cause of it. Next slide. And that's Peggy Whitson, who was one of our long duration crew members. She now works for Axiom Space, which I also have work in connection with them. And look at the difference in her face in flight compared to on the ground. I mean, her eyes are so puffed up, they're almost slit-like. And she was like that the whole time. And that's because the absence of gravity causes this headward fluid shift. Next slide. So this headward fluid shift certainly is a concern, especially as of just a few years ago. We were doing ultrasounds and internal jugular vein Doppler studies. And what would happen if, when you're standing upright, your internal jugular vein is collapsed because gravity is pulling all the blood out of the brain. But in space, with that fluid shift, you will see internal jugular vein distension. And next slide, as they were doing these internal jugular vein studies, were seeing, instead of a normal flow where it's going from the brain down to the back to the heart, you're seeing what they call jugular venous stasis, where the blood just stays put. It doesn't make a flow from headward down to the heart. And sure enough, with the studies enough, they were starting to see not just stasis, but thrombosis. Next slide. And so on this study, there were two crew members that had actual flow that went backward and thrombosis. And one of those was treated with anticoagulants. Next slide. So this thing about this cerebral venous stasis as a manifestation of the headward fluid shifts of the spaceflight-associated neuroocular syndrome has now taken a whole new level of concern. And so they're looking at different countermeasures like lower body negative pressure and artificial gravity. Next slide. So the only imaging that we're able to do in space is with the ultrasound, and we mostly can use that to study eye structures and cerebral structures like the internal jugular vein. But we have started a program of looking at MRIs before and after space flight, and we've seen as I'll show in a few of the slides, shift of the cerebral hemispheres upward. So on this chart here, what you see in the bottom two is the pre and post shuttle flight, where you see a lot. The white is that's basically subarachnoid space fluid, and you see the normal gyral pattern there, but that's not changed between pre and post flight. But if you look at the upper top one, pre is on the left and post is on the right. What you see is a very much of a congested. The CSF spaces are very reduced, and that's from this headward shift. And as the next slide shows, you can actually see the brain moving. Oh, it's too bad. The video, I have a video that shows the difference, but what you see is the pre-flight and the post-flight, you'll see the brain shifting upward. There's also been volumetric studies that have looked at gray matter and white matter, and there are sections in the frontal temporal regions and the basal frontal regions where you see reduction in gray matter. Next slide. So this is something that's of significant concern, and that's just a different view of the same kind of thing, looking at spinal fluid. This slide here, the blue represents the lateral ventricles, the red is the third ventricle around the midbrain, and the fourth is the green, which is in the between the brainstem and the cerebellum. And what you see there is the change from pre to post in astronauts is you see the blue lateral ventricle, the red third ventricle, and the green fourth ventricle. And the dashed lines there are for the controls. So the controls don't have any significant change from their baseline, but there's a drastic change in ventricular volume in all of the ventricles, particularly the lateral and third ventricles. Next slide. That often implies that there are, like you see in hydrocephalus, that something is amiss. And I'll talk a little bit about some performance events. If you look at that picture closely, you'll see that the crew member who'd been working on their spacesuit put the boots on backwards. And you never would want to do that ordinarily. If you've ever skied, you definitely have a bad day. Next slide. So I'll just go through this. We're going to have to go through this pretty quick. Let's skip this slide. This shows you just some things that have happened on missions that were pretty substantial, including switch throw errors and the docking collision that happened on the Mir, where the crew were flying the Progress resupply ship in, and they basically the resupply ship hit the space station and caused it to depressurize. And then robotic arm dysmetria, where the crew member working the robotic arm bumped the satellite. Missed checklist items. This is a fascinating thing, and it gets to this phenomenon called space fog, that crew members don't think as well in space as they do on Earth. And just to give you an example, in the period of the shuttle and the ISS up to now, which is the shuttle started flying in the early 80s and ended in 2011. So it had a 30-year career. And then the ISS started in 2000, and it's now in its 24th year. But on spacewalks, there's been 63 lost items, which is unheard of. So anyway, bad things happen. This was a video. You can go to the next slide too. Unfortunately, I can't play the video, but basically what you see there is as the robotic arm is approaching the satellite, there's a tremor in it, just like you see in an attention tremor in somebody with a neurologic condition. And sure enough, the robotic arm bumps the satellite out of orbit. This was one where a switch throw happened during Apollo 10, the checkout. We can just scroll through this, but the bottom line is the crew messed up. We can go to the next slide, and you'll see this is all the description of it. But basically, on this slide right here, the lunar module control panel in the upper left, there's two switches. And basically, one is the primary guidance switch, and the other is the abort guidance switch. And somehow, when they were doing the test, they didn't realize what position that the switch was in, and it caused the lunar module to go into a tumble. Next slide. So we track these things. This was the Mir Progress collision in '97 that the crew were flying the Progress to attach to the Mir space station, and basically hit a solar array on the Spectre module and caused the module itself to lose pressure. Next slide. And there's just some stories on that. We can keep scrolling through this. We're running way behind. Yeah, I'll skip through this. All this was videos and talks about it. So talking back about transition back to Earth. Now we're going to be in a microgravity adapted state coming back through a high G field on reentry. And next slide. These are some of the things we see on reentry, landing, and post-flight. We see the same kind of disruption in ocular stability called oscillopsia, and also dysmetria, which is kind of a tremor of the extremity as it's doing something. So that short period of reentry where you have to do something, read a display and act on it, might be a challenge. Most of those systems are automated. Next slide. And we'll just go through that. But anyway, we'll see this entry landing system may take up to a day before it's completely resolved. Next slide. Now, this was a study that was done on the space shuttle where the crew was doing a task where they would turn their head actually up or down and try to keep fixated on a target. So if you remember some of the nervous system tests they call the vestibulocular reflex, where when you move your head one direction, your eyes move in the opposite direction to maintain a target fixation. So you see the top there on A, you see the head basically move up, and the eyes should move in the opposite direction, and the gaze has a straight line through the center. You do it post-flight, there may be a little bit of jostling. But during reentry, what you see is a drastic change in that vestibulocular reflex ocular gaze stabilization. So this is something that is very much concerning if you were actually flying the space shuttle. Next slide. Or any vehicle. So if you look at the landing performance in the space shuttle program, what you'll see there, next slide, is some substantial deviation of astronaut performance. And what we see here is that there have been probably about 10% of the shuttle landings were either in the red or yellow. Next slide. When you get back and land and the crew do a walk around after the flight, you'll see the crew that if they're having instability, that would be an indication that they might have problems with egress or escaping from the vehicle. Next slide. And so what we do tests on them, and these are some of the things that they talk about, the crew will talk about, is if somebody is pushing them or pushing them over. When they're walking a straight line, they'll deviate. And one of the hardest things they do is an about face. If you're walking down and then you do a quick turn and go walk the other way. Next slide. We won't be able to show all this stuff. This was a video of a long duration crew member with dysmetria, and another one. Keep going. Sorry about this. We do very sophisticated computerized dynamic posturography that tests your system of balance with and without vision, and also if you have an unstable platform. And so next slide, these are just some scores that show that for a short duration shuttle crew, their score would be where that number 1 is, that's the normalized composite score. So 1 would be your normal score, and you can see that it takes about 3 to 4 days to get back to completely normal. Next slide. It's somewhat better with crews that have previous experience. This was John Glenn's flight, and what you see in the black line is the shuttle crew performance, and then that red line, which is really bad, was the 77-year-old. And I had videos of him. We'll just scroll through these next slides because none of these videos. This is a picture showing him with a wide base gate. So what we see here is for shuttle flights, the normal recovery is a couple of days. And for long duration flights, the recovery is roughly 2 weeks before you're back to normal. So that just shows you the difference in being adapted for a longer period in microgravity. Next slide. And we do tests on the crew. This was a test that we would do on the crew called the Neurologic Function Rating Scale, and essentially is a field sobriety test. Like if you unfortunately get stopped by the police after being at a bar. And what you'll see there is, the difficulty with the tandem walk and heel to toe walk. And also the ability to follow a target smoothly going from side to side. Next slide. We're also doing other tests now in the field for long duration crew. And these are just basically sit to stand, which is a pretty simple test, or get up from lying down. And then being able to stand for a couple of minutes with your cardiovascular system is compromised. It's not able to keep the heart blood pressure up high enough. And then the tandem walk, which we know is a pretty good test. Next slide. And what you see there is that one is for these long duration crews, every crew member had findings that would be indicative of vestibular or cerebellar dysfunction. In other words, they would have failed the field sobriety test. And they also have motion sickness, particularly if they're doing any kind of head motion. So what happens is when they're walking around after flight, and this was a picture of the crew after several hours, they all lock arms to hold themselves up, and their head never changes from their body. So they don't turn their head looking at something, they turn their whole body instead. Next slide. And then this just shows you what people aren't able to do. And, essentially about half the crew can't do anything immediately post-flight, and even after 5 hours, there was quite a few that needed assistance. So what does that tell you is if they had to do a landing without any recovery forces, they would have some challenges. Next slide. And these are just some of the references. I have a book chapter that if you're interested in this in more detail, I can send you a copy of. So anyway, in summary, the nervous system, like all the other systems, are challenged by microgravity and other spaceflight parameters, and essentially all phases of spaceflight have some component of that effect. We talked about this microgravity, the absence of gravity, but there's also things in the vehicle, the things that we take for countermeasures, and things like sleep deprivation or circadian shifting. The nervous system is the most rapidly affected by spaceflight, and the most significant effect we see now is this spaceflight-associated neuroocular syndrome. Next slide. And here's my contact info. I have an academic appointment at Baylor College of Medicine, but I also have a professional email there as well. And that's my last slide. Well, actually, you can go to the end. That was taken by Leroy Chow on his Expedition 10 mission with a camera. Any questions?
Thank you so much. Thanks, Dr. Clark. Yeah, great. Thank you so much for the talk. So would anyone have questions? You can just turn on your mic and you can just ask.
Hi, Dr. Clark. Thank you so much for taking the time to give this talk today. My name is Emma Hartness. I am a medical student researcher with the International Committee for Commercial Spaceflight. And regarding SANS, I was wondering what your thoughts would be considering the similarities between SANS and idiopathic intracranial hypertension. What your thoughts would be on using acetazolamide either in spaceflight or prophylactically to kind of treat those symptoms, because I can imagine, as you said, not being able to read your checklist and not being able to get a new glasses prescription in space for your new hyperopia could be a large problem.
Yeah. I mean, so you use acetazolamide for acute mountain sickness. This is kind of first of all, idiopathic intracranial hypertension or pseudotumor cerebri it's mostly in women, and they have a higher body mass index. That SANS seems to be more often in men. Women get it, but it's not nearly as much. So fundamentally, we don't think they're the same etiology. There has been, I think, a few cases where they have used Diamox, and I could, there was a transient reduction, but you can't. The problem with that is you might precipitate kidney stones, which are already an issue in space flight, and they're looking for other countermeasures. As far as the glasses go, what they do is they call them space anticipation glasses, and they're basically refractive glasses that you can just basically tune yourself to the best vision. And that seems to be the best thing right now to do. Ironically, if you're a myope, in other words, the pushing back of the globe and globe shortening actually makes your globe perfect. So myopes don't have a problem. It's the hyperopes, or it's the pilots who see perfect, near and far, that are more affected than myopes. So, but anyway, there's a lot of things that they're doing to try to adjust it. One of them is to do lower body negative pressure and suck the blood back down into the lower extremities and things like that. I think what they're really trying to do is to have a better understanding of the pathophysiology and target a response.
Yeah, thank you. That's very interesting, especially the adjustable glasses. That sounds very useful. Thank you.
we have any?
This talk is available for everybody, and if you're interested, I can send you the book chapter that's in Principles of Clinical Medicine for Spaceflight, with which much of this is, has been geared towards.
Yeah, I'm sure we can
And also
circulate
I've got
that.
other, I've got a huge SANS file. Right now we're looking at it using optic nerve sheath diameter. That's actually been used in mountain to evaluate HACE, high altitude cerebral edema. The problem is it's really only valuable if you have a good baseline, because the variability in what's considered an abnormally dilated optic nerve sheath diameter is very wide unless you compare it to yourself. Okey-doke. Well, thank you all.
Sorry, I've just got a question. So you were talking about the motion sickness that astronauts get, and I was just wondering whether, there's been any studies into the genetic predisposition to this, whether, some people are more predisposed to this or not.
There are some biomarkers that they're looking at, that might be a factor. So I could send you the articles on that if you're interested. It basically is it's called the one carbon metabolism, and maybe there are people that have effects on B12 or something. So there might be a genetic predisposition, but it's the problem is there's tons of different there's genetics, and then there's so you can do omics markers, but also it's the genome that's really the factor. In other words, it's a combination of our genes, which we're stuck with, and then there's the combination of what the environment plays, and really the focus is always on, unless it's a serious life-threatening condition where they're trying to reprogram the genes with CRISPRs, snipping different things out. It's always focused on the epigenome, the expression of your genetic propensity.
And you mentioned earlier that the adaptation is much slower when we go to space. Does this improve with each progressive space mission?
Yeah, there's no question. If you do the balance testing, that and I could show you that slide. Let's see if I can pull it up on my talk, but there's no question that let me see if I can share my screen. That if you have flown multiple times in space, that you have an advantage. Now, let me see if I can find this one. Oh, this is it right here. So can I share my screen, or can you allow me to? Okay, let's see. So if you look at this slide right here, can you see that? Trying to make it as big as possible. Can you see that slide?
Yep, we can.
So this is a crew that this is the equilibrium score, and for a rookie crew is 0, for a crew that's flown once before, and then a crew that's flown twice before. What you see there is the rookie on the landing day is way below the clinical abnormal range. The crew that's flown once before is right at the limit of it. In other words, they probably would be okay, but they're right at the limit. And then for somebody who's flown twice, their score is, even on landing day is much better. So there is some experience, space flight experience that affects the ability to rapidly recover. Their adaptive time constant is enhanced. So yes, prior space flight experience definitely can have an effect in recovery.
Are there any other questions?
Dr. Clark, thank you very much for the lecture. I'm an aerospace engineering student, so I don't have such high expertise in medicine, but I wanted to touch upon the fact that astronauts experience nausea or different symptoms shortly upon arriving to ISS. And I wanted to ask whether there are some practices or something in place before the flight, because there's not such a long time span between when you land the spaceship and when you arrive to the ISS. So do they get maybe some medicine, or do they get some
yeah.
exercises that would to some extent help to prepare them for the adverse effects of zero-G or microgravity?
Yeah, so the Russians have been a big proponent of using cross-couple Coriolis stimulation for motion sickness adaptation. In the US, we use it for military flight crew. When I was in the Navy, we had a program where basically you sit on a chair, you spin around at a certain RPM that you can control, and then you make head movements. And the faster that you rotate, the more provocative it is. And usually people they'll be barely able to do 1 or 2 RPM with the head movements. And when they go through a course that might take a couple of weeks, by the end, they're up to 20 RPM and moving their head just fine. So they use that, and that has worked for air sickness. The Russians still do that, and the US or NASA has said, well, we don't think it's helpful. And part of it is it's very labor intensive. It's an hour twice a day for 2 weeks, and the crew just basically they don't have the time to do that, especially just before flight. So what they do is they'll just take a prophylactic pill of it's Phenergan and Dexedrine, either anticholinergic with a stimulant, which seems to help, or anticholinergic with another type of stimulant like modafinil. So the reality is there's multiple ways, both pharmaceutical and non-pharmaceutical, that seem to be beneficial. The problem with using Phenergan or Dexedrine is that it's anticholinergic, so it gives blurry vision and your mouth gets real dry. And it also can have effects on memory. And the other thing is there was cases that happened in the US program where, if one is good, a lot's better. And there was one crew member that was like, I just don't want to get motion sickness. They took a pill and, I'm not sure about that. Took another one. When they got up there for a day or two, they were just like a zombie. Literally, they were just like, they couldn't do anything. They didn't have motion sickness, but they were non-functional. So that's always the downside, is no matter what you have, and it's, in medicine, that's the thing is, the treatment shouldn't be worse than the disease. So, and we test crew beforehand to make sure they don't have a really bad adverse effect. So, in general, non-pharmaceutical approaches, I think, are a better way to go. There's electronic AccuStim, the P6 pressure point for acupuncture, and they have an electronic AccuStim device. So there's other non-pharmaceutical ways to try it. I think for commercial space flyers that are only going to fly once, and you're paying a lot of money for a trip, you don't want it to be a lot of money and just be sick. So I would say it's probably worth taking it there and accepting the consequences.
Thank you.
Cool.
Do we have any other questions?
All righty. Well,
guess,
if you do,
yeah.
you can always email me, but
Yeah.
I'm happy to answer whatever, suits you.
Great. So thank you so much again, Dr. Clark, for giving us this talk. I think we all learned a lot, and so much was covered about, such a wide kind of field.
Sure.
So thank you so much. Great.
All righty. Thanks a bunch. See
I
y'all.
hope you all have a good evening.
Take care.
You too.